Okay, let's dive right into this rapid-fire clinical exam explainer. Today, we're serving up high-yield infection and sepsis MCQs with absolute focus and zero pauses. We're hitting the exact source statements, the options, the underlying reasons, and those absolutely crucial exam pearls you literally just have to lock into your memory. Let's go.
Question 1. Which of the following components is included in the initial Sepsis 6 management bundle, designed to be completed within the first hour of suspecting sepsis? Is it A, intravenous fluid challenge, B, intravenous antibiotics, C, blood cultures, D, full blood count, or E, all of the above?
The correct answer is E, all of the above. The reason? Well, the Sepsis 6 protocol has to be initiated within exactly 1 hour of clinical suspicion to actually improve survival. The protocol breaks down into 3 actions to give and 3 actions to take. You're giving oxygen targeting an SpO2 greater than 94%, IV fluid crystalloids at 30 milliliters per kilogram, and IV empiric broad-spectrum antibiotics within 60 minutes. Then you have 3 actions to take: blood cultures drawn right before those antibiotics, a full blood count to monitor for things like sepsis-induced DIC, and a serum lactate. A lactate greater than 2 millimoles per liter, that reflects organ dysfunction.
Question 2. A 26-year-old pregnant patient is diagnosed with an acute urinary tract infection. Which antimicrobial class provides the safest therapeutic profile for both the mother and the developing fetus? A. Metronidazole, B. Aminoglycosides, C. Cephalosporins, D. Quinolones, or E. all of the above?
The correct answer is C, cephalosporins. They're a pregnancy category B, highly effective against E. coli, and just have a fantastic safety profile overall. But you've got to know the high-yield exceptions here. Nitrofurantoin's super effective, right? But you must avoid it near term because of the risk of neonatal hemolytic anemia. Sulfonamides, contraindicated in the 3rd trimester. They can actually cause neonatal kernicterus. Fluoroquinolones carry risks of fetal cartilage degradation, and tetracyclines literally cause permanent tooth discoloration and inhibit bone growth. Always remember, pregnant individuals must be screened and treated for asymptomatic bacteriuria.
Question 3. Patients with a penicillin allergy are least likely to have a cross-reaction with which one of the following? A. Synthetic penicillins, B. Carbapenems, C. Cephalosporins, D. Monobactams, E. None of the above.
The correct answer is D, monobactams. Now, cross-reactivity happens because of that beta-lactam ring structure. The exact risk profile looks like this. Carbapenems have about a 1% cross-reactivity rate. Cephalosporins sit roughly around 5 to 7%, but monobactams, like aztreonam, they exhibit a 0% cross-reactivity risk with penicillins. Oh, and here's a massive exam pearl for you. Cilastatin is not an antibiotic. It's actually a peptidase inhibitor.
Question 4. A middle-aged patient presents to the ED after a fall from a bike. The attending paramedic administered parenteral penicillin, following which the patient developed wheezing, facial flushing, and a rising pulse rate of about 150 per minute. Blood pressure is 100/60. Keeping in mind the possible diagnosis, what is the drug of choice here? A. Epinephrine, B. Continued administration of penicillin, C. Change of antibiotic to some other class, D. Steroid injection, E. Administration of Ringer's lactate.
The correct answer is A, epinephrine. This patient has clearly developed acute anaphylaxis, which is a type 1 IgE-mediated hypersensitivity. Immediate intramuscular epinephrine is the undisputed drug of choice. Look at these dosing pearls. You administer 0.3 to 0.5 milligrams IM every 5 to 15 minutes. For refractory cases, you're looking at a continuous IV infusion at 0.1 micrograms per kilogram per minute, and your adjunctive cocktails include diphenhydramine, ranitidine, methylprednisone, and albuterol.
Question 5. A surgeon operating on an HIV-positive patient sustained a needle stick injury. Which of the following is the most effective post-exposure prophylaxis for the surgeon in this case? A. No treatment should be initiated. B. 2 or 3 drug therapy started within hours of exposure. C. Single drug therapy started within 24 hours of exposure. D. Triple drug therapy started within 24 hours of exposure. E. None of the above.
The correct answer is B. 2 or 3 drug therapies started within hours. Post-exposure prophylaxis is most effective when started within hours, definitely not days. The standard is a 2 or 3 antiretroviral drug combination. Now, the absolute key exam pearl here is identifying the highest transmission risk. It's needle stick injuries on the non-dominant index finger involving hollow needles. Always wash immediately, And if the source status is unknown but high risk, start PEP while testing is happening.
Question 6. With the use of an alcohol-based antiseptic, how much reduction in bacterial count occurs on the operative skin site? A. 50%, B. 70%, C. 80%, D. 95%, E. More than 95%.
Boom! More than 95%.
Correct answer is E. Just one single application of a concentrated alcohol-based agent achieves a greater than 95% reduction in skin bacterial count. But here is the vital, high-yield warning pearl you absolutely must know. Never let alcohol-based fluid pool on the patient's skin or drapes. Why? Because it can literally ignite when surgical diathermy is used, causing severe burns to the patient.
Question 7. A patient presented to the surgical clinic with pain and redness in his left forearm following a wound sustained from a bike fall 1 week ago. On exam, there's a 2 by 2 centimeter wound over the forearm with erythema, blanching, and severe tenderness. The pain and redness are increasing progressively. A diagnosis of cellulitis is made. What should be done before starting empiric intravenous antibiotic coverage? A. Skin biopsy. B. Hand elevation. C. Blood cultures. D. X-ray of affected forearm. E. Directly proceed to intravenous antibiotic therapy.
The correct answer is C, blood cultures. In patients requiring admission, blood and wound cultures must always be drawn before giving the first dose of broad-spectrum empirical antibiotics. You do this to prevent sterilization of the cultures. Core pathogens here, you're looking at beta-hemolytic streptococci, staphylococci, and Clostridium perfringens. The clinical hallmark is pain completely out of proportion to physical findings, along with systemic toxemia. For supportive care, elevate the limb to reduce edema and use warm compresses to increase localized blood flow.
Question 8. A patient presented 3 days after a laparotomy to the surgical OPD. Examination of the surgical site shows pus discharge from the lower 1.5 centimeter section of the wound. What is the grade of this wound infection according to the Southampton scoring system? A. Grade 3B, B. Grade 4A, C. Grade 4B, D. Grade 3C, E. Grade 5.
The correct answer is B, grade 4A. The appearance of clear pus discharge classifies this right away as a major complication, so grade 4. But the exact breakdown depends on measurement. Since the discharge is restricted to a single point measuring less than or equal to 2 centimeters, it's specifically grade 4A. If it were a wider segment greater than 2 centimeters, that's grade 4B, and grade 5, that's deep wound dehiscence with actual tissue breakdown.
Question 9. Which of the following is the most common cause of aspiration pneumonia or lung abscess outside of the hospital setting? A. Staphylococcus aureus, B. Bacteroides fragilis, C. Streptococcus pneumoniae, D. Legionella, E. Anaerobes. The correct answer is E. Anaerobes. Think about it like this. Outside the hospital, in a community setting, at least 50% of lung abscesses and aspiration pneumonias are purely anaerobic, with another 25% being a mix of aerobes and anaerobes. You really have to contrast this with the exam pearl for nosocomial, or hospital-acquired pneumonia, where 60 to 70% of those cases are caused by gram-negative rods.
Question 10. Which of the following conditions is the most common primary source of gram-negative sepsis? A. Pneumonia. B. Lung abscess. C. Urinary tract infection. D. Cholecystitis. E. Wound infection.
The correct answer in C, urinary tract infection. UTIs are absolutely the most common primary source for gram-negative rod bacteremia and subsequent sepsis. And the vital exam pearl to lock in here, E. coli is the undisputed leading offending pathogen. Just think about that for a second. When the pressure is on and the clock is ticking on a crashing patient, how many lives depend entirely on the instant, rapid-fire recall of these exact clinical protocols? Keep studying these topics, lock down these pearls, and stay ready.